Medical practices are quietly bleeding collectible revenue right now. It happens out of sight, and for many owners, the root cause remains completely hidden. This chart shows the scale of the problem. National initial claim denial rates climbed to nearly 12% through 2025. The catalyst for this spike is automation. Payers are deploying AI-driven review tools that scan submissions and issue denials within seconds. The impact is widespread. 41% of healthcare providers are now dealing with denial rates exceeding 10%. Compare the automated speed of those payer AI tools against the human reality on the ground. Revenue cycle teams are currently 43% understaffed. This dynamic shifts the entire burden of proof onto a practice's already stretched billing staff. When an under-resourced in-house team is forced to fight automated payer algorithms, the practice is mathematically outmatched. The standard approach to in-house billing is obsolete. The pressure is especially severe for practices running on the PrognoCIS EHR platform. PrognoCIS is an incredibly powerful system because it gives providers the ability to deeply customize workflows for their specific specialty. But that high level of customization creates an exceptionally steep learning curve for anyone new to the system. Every payer-specific scrubber, template, and modifier logic rule has to be actively and manually maintained within the software. The moment an experienced biller leaves your practice, those customized rules experience configuration drift. Maintenance stops, formats degrade, and errors slip directly into the claims process. Because of this specific complexity, practice managers report it takes an average of 60 to 90 days for a new hire to become reliably productive on their specific PrognoCIS setup. The platform's greatest strength acts as a structural vulnerability. Your entire revenue cycle is tied to a single employee's institutional knowledge. Let's examine the actual financial reality of maintaining that in-house billing team. This stacked bar chart breaks down the true baseline cost. Factoring in base salary, employer taxes, benefits, and paid time off, a single fully loaded in-house billing specialist costs your practice between $55,000 and $75,000 annually. Standard 2 to 3% annual raises no longer work for retention. The industry has seen a structural reset in compensation. Current turnover rates sit at a massive 40% for front office staff and 33.3% for billing support roles. Every time a frontline billing specialist walks out the door, it costs $25,000 to $30,000 in recruiting, onboarding, and lost productivity to replace them. And that replacement cost overlaps directly with the 60 to 90-day prognosis training gap we established earlier. Practices are paying massive premium replacement costs to buy themselves 90 days of elevated claim errors and delayed cash flow. Those elevated error rates carry a strict direct penalty. The administrative rework cost hits $47.77 for every single Medicare Advantage denial and $63.76 for commercial denials. Look at a mid-size practice submitting 300 claims a week at a 12% denial rate. That rate guarantees 36 denied claims every week. Multiply those 36 by a conservative $50 rework cost, generating $1,800 per week in pure administrative waste. The true cost of the in-house billing model is intentionally hidden inside delayed cash flow and unworked, abandoned claims. But an operational countermeasure exists: EHR-native outsourcing. In this model, an outsourced team of credentialed specialists logs directly into your practice's existing PrognoCIS instance and manages the workflow starting on day one. The institutional knowledge of your customized templates and scrubber logic lives in a permanently documented playbook, entirely removing staff turnover from your risk profile. It also layers AI-augmented workflow tools, like predictive routing and automated claims audits, directly over the human team to stop denials. Operationally, this model maintains a first-pass error rate below 1%. EHR-native outsourcing is the only structural method that neutralizes the prognosis learning curve and the payer AI threat simultaneously. Now let's run the final return on investment comparison. This chart compares the fully loaded in-house cost on the left, running up to $75,000, against the Staffingly outsourced model on the right, at $20,748 per year. That outsourced rate scales out to just $399 per week. This delivers up to a 64% reduction in billing labor costs, carrying zero recruiting fees and no benefits load. And instead of suffering through a 90-day hiring and training lag, Staffingly executes a rapid 14-day go-live implementation. This table illustrates the real decision matrix. Practices choose between the illusion of control plagued by high turnover or systematic stability delivered by outsourced experts. If your practice is bleeding revenue through denials, the next analytical step is to start Staffingly's 14-day risk-free pilot. Shifting from a vulnerable in-house setup to a specialized outsourced model is the mathematical defense required to survive.